Next speaker is one of my favorites, the Nicolò Pini. Nicolò. Nicolò. Oh, I didn't know they.
I didn't see that coming.
So sorry.
Nicolò
Pini is in Cagliari with COVID, unfortunately. Sorry, this is end of the day, no. Nicolò Pini. It's Italian names, all Italian. It went into my Italian part of my brain. But yeah, no need for more introduction, I guess.
Yeah, thank you for the nice introduction, Antonia. Thanks everybody for your time, and I don't know what Antonia was thinking when she put me like the last day, full day, because I don't want to, I want to spare you too much time. So I'll try to go as quickly as possible, trying to cover everything. So, full disclosure, none of this work is intrapartum, so I won't, lose you from here. But I think, it's relevant in the sense of many of the discussion that we have been having these past few days. Something also Cassandra brought up many times, which is about the fact that we tend to think about low middle income countries, but I think it's actually more appropriate to say low middle income settings, as we also, for example, in the US do have a lot of low middle income settings, and you will see that some of these results actually are also valid in there. So, okay, so given that sometimes images are worth more than 1,000 words, this is some of the pictures depicting where some of the data I will be describing to you today are collected. So as you can see, it is not the usual clinical settings that we're used to, and I think highlights the importance of a lot needs to be done. So in order to introduce the framework that we've been trying to develop also with some of the work I've been conducting with Maria in the past, and now with Bill Pfeiffer at Columbia, is the idea that we do care a lot about risk factor that could play a role in the antepartum period. So that in a way is similar to something that Antonia was actually describing yesterday when she was showing like that slide about the risk, the risk assessment. We do know that there are some factors we do play a role in increasing or decreasing someone's risk, and that risk can be, again, during labor, or could also be later on in life. So here, just to show you before actually getting to the nitty-gritty of the work, here are some contextual and environmental factors, not going through all of those, but you can name it, about all the adversities and all, again, this contextual factor that some of these moms do actually endure while they're pregnant. And again, calling Cassandra again, you can think about the fact that many of these are also experienced in some marginalized communities and historically marginalized community. And so it's not such a big leap to think about translating some of these results in other settings which are not in developing countries, for example. So again, a lot of the framework is trying to think about promoting maternal and fetal well-being, which goes beyond just a healthy delivery. Keeping in mind, and I think this also goes back to some of the discussion that we've been having earlier today about the fact, how can we promote the idea that fetal monitoring antepartum or intrapartum is really important and can actually have or shed light on long life adverse consequences if something during pregnancy might go wrong. And so, just to summarize a little bit, this is a beautiful slide, which of course I didn't make it because it comes from someone much smarter than I am, who's actually at Columbia, and funny enough, it was Bill's first postdoc, now as a full professor at Columbia. She had this beautiful slide trying to depict all the different factors that may play a role in shaping someone's pregnancy, as well as have an impact on, again, long life adverse outcomes. And as you can see here, many of the, let's see if you can see my pointer, there we go. So many of these, some of you or many of you have touched throughout this workshop, and I think it really highlights the fact that pregnancy is a very complex set of mechanisms. It involves like some more biological mechanism and some kind of exposures, which is the thing that I've been mostly focusing on. So just to highlight a little bit what I'm going to present, which is a summary of some of the studies that we've been conducting in this area. We'll be talking about maternal exposure during pregnancy, so in utero exposure to substance. Then we'll have some results about metabolic diseases, so gestation diabetes, and then we'll talk about sleep and the role that sleep may play in promoting both fetal and maternal health. So I will start by this study which we recently published and doesn't have nothing to do with signals. The signals will come later in the next slide, but this is to say how much in utero prenatal exposure might actually have a negative impact on pregnancy. And so here, using data from quite a few pregnancies that were collected in South Africa, some were actually collected in the same setting that I showed you earlier, we found that dual exposure to both drinking and smoking during pregnancy actually increases someone's risk of stillbirth. And that, I think it's really important for two reasons. One is that we were able to collect both magnitude and timing of that exposure. And so in a way, the results are really showing the fact that if a pregnant woman continue consuming alcohol and smoking beyond the first trimester, actually that risk is, as you can see here, is elevated about 3 times, which really points out to the fact that this is something, you know, we could maybe include in our model, or really think about these dichotomous results about yes or no beyond a certain point in pregnancy. And I think it's also worth mentioning here, but this data set was comprised of majority of people from South Africa, so in a developing country, but also part of this, showing up right here, you do have also data from the Northern Plains, which in the US, which I don't know how many of you are familiar with that, but it's definitely one of those examples where we talk about low middle income settings rather than, you know, middle income country, which definitely US doesn't fall into that. And just to plug and play a little bit with the signals in here, some of so a subset of those moms, which showed the results in the previous slide, were also their CTG collected during pregnancy a multiple time point. And here I'm just reporting one of the results. Again, there's more details in the paper, but I think it's important to highlight what's happening here. So basically, on the x-axis, you do have different, it's not too small, sorry about that. You do have different amount and timing of alcohol exposure, and what we can see is that fetal heart rate is elevated in those consuming what we define as high continuous or also high quit early, meaning those who had assumption of alcohol throughout pregnancy, or they had alcohol consumption in the first trimester and then quit. Just a note to that, this result, we made sure that the assumption of both alcohol and smoking did not happen soon before the CTG and all of that. So this is, supposed to be some long-lasting effects of such exposure. The next thing that I want to talk to you about, and again, this goes back to the idea of can we define profiles of risk that can actually have a positive impact, meaning improving our precision in the models that we're doing. So not going to the details of the protocol and all that, we did have also fetal ECG recording on these participants collecting using Monica device, which many of you are familiar with. And the idea is that we had this cohort with pretty much 50-50 in terms of like controls and fetus whose mom was GDM. And again, I'm not going to a bunch of details how we did the fetal extraction and all that. This is some of the work being carried with Martin, so thank you, Martin, for that. But what I want to point out is the fact that we do have the opportunity, this also comes from my previous work with Maria, the fact that we can extract some meaningful parameters from this signal and actually kind of think about a risk profile. So here there's a lot of details about how we did the model and all of that. But this is just to say the thing that what we found was that GDM fetuses on average, and this is valid like in the first, second, third trimester based on the data that we do have at some of the profiles of risk that it is reported in the literature, again, as associated risk, not only during pregnancy, but actually later on, which is the profile having higher R rate compared to control, but then having lower variability. And I think this is really important also based on some of the discussion that we did have today about the fact that it is not only in pregnancy we do see some of that, but actually some of these differences, some of these profiles of risk might go beyond pregnancy. So as an example, I'm reporting here just one example, but there's many of that, talking about these very things. So higher heart rate on average, but lower variability, which speaks to an imbalance in the ANS controls. And this is also being reported in the literature for, for 6 cases. So again, our profile, we start in utero, but actually gets carried over also in early in life. So leaping through the last, it is the work we've been conducting, investigating the role of sleep. As you know, there's a lot of research going on and a lot of interest even in NIH about sleep and the role that sleep can play promoting positive health, as well as moderating the effects of long-lasting adverse health outcomes. And leveraging the data that we collected, the one I showed you in that cohort of about 110 participants, since we were able to get clean data extracted by Monica, what we did was use that that maternal signal to be able to answer the question: do we see a relationship between sleep and someone's risk and relationship with some of the health factors or environmental factors that I described earlier. So, not going into much of the details of this. This is some of the results that we're able to get. This is just a bridge to get to the next slide. We're actually trying to find a link between that. But what we're able to do is to develop an artificial intelligence algorithm only taking as an input the maternal ECG and getting you as a result a sleep stage classification, which mimics what is done at the clinical level. So you can see here 2 different examples for the same mom, different patterns, 2 different days. But this is to say that we can get such granular information about the sleep, which is actually getting you such more quantitative data with respect to some more qualitative stuff. So you can get to estimate, for example, for REM or non-REM sleep, and there's a lot of literature right now being able to link some of that to health outcomes. So, I think going through one of the last slides I do have, which is, again, in that cohort of mom, we performed this simple association, which we, again, wanted to get an understanding of is the relationship between sleep and some of the contextual factors. Again, going back to the point that this is probably, something that we can think as a modifiable factor that, again, puts you at high risk, and going in a second about the results. But can we actually act on some of these factors, again, on metabolic disease or even actually on sleep health to be able to promote more positive health? So what we found, again, going back to the hypnogram that we saw in the previous slide, what we did was basically divide the different level of cardiac index. Usually cardiac index, and I'm sure many of you are familiar with that, is often used as a proxy of SES. Basically it's telling you on average, how many people do you have divided by the number of rooms you do have in your house. And so, as you can imagine, low-income setting is really reflective of SES in the sense that we do have differences. So here, we just divided the distribution of cardiac index in different tertiles. So in third tertiles here, the one which is labeled top, will mimic pretty much the condition of more westernized countries. So you do have maybe you do have 1 person per room, or even fewer than that. Then in the middle, you have a condition where you maybe are, like 0.5 or something like that. And in this bottom tertile here, you do have really low cardiac index, where basically that will tell you that there's conditions such like there's more than 10 people in a single room in a house. And what you can see is that there's a relationship between the percentage of REM sleep as a function of cardiac index controlling for the duration of sleep. So there were no differences to duration time, but you do see this relationship between cardiac index and percentage of REM sleep. Again, to point to the fact that there's a lot of literature showing that, for example, having lower percentage of REM sleep increases the risk of developing cardiovascular health disease, but also there's some more recent literature showing how lower percentage of REM actually increases your risk of developing diabetes and also GDM as well. So this points out to the fact that these are some modifiable factors that we can add to, antepartum to be able to potentially reduce the risk. We are actively working on replicating some of the results with the fetus. Unfortunately, I don't have the results yet, but hopefully by the next time there will be more to share. Again, I hope I still have most of you. I'm not pretending everyone is still following. So here are just some of the summary of what I tried to describe to you. I think the main points are the fact that contextual and environmental factors do actually play a role in trying to get an understanding of some of the physio data, which I totally understand is important, is doable, but sometimes this is also important to merge all of that together. I hope I was able to convey the message that wearables do offer an opportunity for being able to monitor these population, marginalized population, historically marginalized population in developing countries in a more comprehensive and, I would say, in-depth way. Again, for aiming to profile antepartum risk as well, maybe during intrapartum. I mean, there's a lot of work to be done. Second to last, I hope that it's clear, or at least that was also based on the previous talk, that conducting research in developing countries or low middle income settings do offer more opportunities than challenges. As you can see, I put for the most part in parentheses because sometimes it doesn't feel that way, but I think we should really push ourselves to go beyond our comfort zone. And then the last one, which I think we do see the fruit of that, is the fact that we shouldn't be afraid of branching out and collaborating. We do have a lot of collaborations with industries and other partners to be able to carry this resource, because of course we cannot do it by ourselves, and of course happy to talk with anybody who has ideas to implementing something in this core that we do have. And that was it for me, and thank you, and here are some of the funding agencies that sponsor the work and some collaborators along the way. Thank you, everybody.
Most impressive and speedy. Questions, thoughts, comments?
Yeah, cool talk. I'm sure that can be unpacked into a whole afternoon. I'd like to ask about the slide where you talk about the relation between sleep, the REM state, and I think it's interesting, right? Because like you said, there can be something potentially done about it, and it's probably just scratching the surface of using the crowding index. It's a cool index because it's easier than some others. Do you guys have ideas about what's really going on? Is it stress? Is it just that too many elbows and you just don't sleep? Is it REM sleep we should be looking at, or maybe non-REM? Because really, this was sort of my first intuitive thought was I would have been looking at the non-REM because that's your essential. On the other hand, REM sleep is where your synaptic development happens, so it probably sucks when you don't have enough of that as a baby. What are your thoughts about really the physiology and implications?
You mean are talking about the mechanisms underlying some of this potentially?
Yeah.
Okay. So, well, I mean, I do have the results of non-REM. Happy to go through that because, as I was mentioning, here basically with the artificial intelligence, you do get all of these stages, which are describing here. So maybe you want to then collapse light and deep, or we can do whatsoever we want to think about. I mainly focus on REM based on some of the results that I described, which were talking a more precise link between, let's say, gestational diabetes and, let's say, percentage of REM. In the specifics of gestational diabetes, there's, the research, the main hypothesis is the fact that not getting enough REM sleep does not promote hormonal releases, which are thought to lower your glucose levels, as well promote some regeneration in some of the organs devoted to promoting your a balance of your insulin level. So that's one that is one mechanism that has been hypothesized. And I'm totally into the mechanistics part. I just want to I want to here, as you pointed out, stress a little bit more about the fact that irrespective of the mechanism, in a way, which is kind of a cynic way to think about it, this is something we can intervene without sometimes asking too much about the mechanism. Can we actually do something? So I mean, I'm not presenting that here, but we do have a research going on with another collaborators that is carried out, I would say 20 minutes from Yale, where basically she is doing some of this in the sense that she's carrying over an intervention on Latinx moms, and she is, because she's a clinical nurse and she's carried out the work, but based on some of these results, she's trying to really promote that knowledge about sleep health is important. And that, I think, it's important for two folds. One is, again, promoting maternal health, but at the same time, some of that hopefully will get translated to the sleep practices for the baby. And because we know, for example, the Latinx, but in general, marginalized population have very poor sleep routine, also for babies. And who knows, maybe the mom learning a little bit more about themselves will promote also improving babies from newborn to like 6 months early time. So that was, I should have conveyed that better. So thank you, Martin, for pushing me for that.
That was very detailed and deep, mechanistic. Last chance for a quick comment, Cassandra. I think everyone is ready for a break.
No, please don't. Just wanted to say your talk was great. I think, again, kind of going into even bridging when we're talking about getting really big databases together and what you would want in them. I think that we do not enough of the maternal and physiologic data and all the data we can get and extract from the chart. So interesting, like for the GDM moms, like what were her blood glucose levels throughout, labor? We take those every hour. How do you incorporate that in the machine learning, and how does that affect the fetal heart rate tracing? So I think there's so much depth of other data that's outside of, the fetal heart rate that can potentially be confounders or affect them. Like, should we be treating gestational or diabetic moms differently when we're reading their tracings versus another, baby's tracings? And I think that really making our databases and our analyses of these things be really rich, I think is very, very important. So really cool work.
Thank you. Appreciate that.
Okay, so thank you very much to everyone today. We survived! Party time!